Well, welcome back. This is a talk on inotropes and vasopressors, and specifically an exploration of why we would use them and when to use them. And this is in patients with shock and some kind of organ dysfunction. It's a follow-up talk on the use of fluids in the same context. So the indications are going to be situations where there's hypotension or tissue hypoxia, and specifically a mismatch between VO2 and DO2 that's not remediated by fluids alone. And so typically, inotropes and constrictors are kind of considered in consort because it's like you give patient fluid, their pressure might improve a little bit, their oxygen delivery might improve a little bit, but you're not quite there. And then you're wondering, well, what do I do next? And often it's sort of like do I give them a pressor or an inotrope or both? So a lot of times these decisions are quite intertwined, but usually they come up in the context of someone who's refractory to fluid therapy alone. So kind of specifically, so an inotrope would be used in a situation where the DO2 or oxygen delivery, and specifically the cardiac output component as opposed to the blood and hemoglobin component, is inadequate. So in this case, you need more oxygen delivery. You need to boost up your heart function. And the implication here is you've already given some fluid, and that's not doing the trick. Vasopressors, on the other hand, would be used in situations where you have an inadequate blood pressure, and this might be also in the context of inadequate oxygen delivery. But even more specifically, if you have a decent oxygen delivery, let's say you have a PA catheter that's saying that your cardiac output is like 15 plus, and you know that your hemoglobin mass is totally fine. So that's quite likely an oxygen delivery that exceeds whatever the body needs at that time. But if the blood pressure still is low and you have, say, a MAP of 55 or 60, then that clearly is a clear-cut case for a vasoconstrictor. So we'll go into inotropes in a little bit greater detail and just talk about some of the contexts where they might be used. So low oxygen delivery inferred from metabolic acidosis, elevated lactate, mental status change, rising creatinine, oliguria. Like this is the whole shooting match. And if you've got a CVP catheter or even a PICC line, you can get some samples of central venous blood and maybe even throw low central venous O2 sat onto the picture. So this is a case where you definitely need to do some resuscitation. You might have started with fluids, but now you found a patient that's not fluid responsive, and so still they have everything suggesting that oxygen delivery is poor, not doing anything with fluids. That's a time when you would want to start an inotrope. Let's say you have an echo showing that after fluid administration with all these abnormalities, the ventricular function is poor. Often, sometimes you see that first thing when you're taking a look at a patient, you just slap an echo probe on, you see the ventricular function is not really what it's up to what it should be. Definitely a clear case where you want to start an inotrope. So let's take a look at someone who is hypotensive. So again, let's say you have an echo, and first off, you look at their heart. At end of systole, there's plenty of blood left in the heart, so you don't think there's that much role for additional fluid loading. And the function looks diminished, so that's kind of an overlap of what was talked about above. That would be a patient right off the bat where you'd say, oh, this patient needs some kind of inotropic support. Or let's say a little bit further down the line, you actually load the patient with fluid, and multiple assessments are valid here. You can be using echo, you can be using IVC, you can use systolic pressure variation, leg lifts, whatever, but the function is diminished on echo. So further, you've tried some fluids, and now again you have a lot of volume in the heart, probably not any role for additional fluid loading, time for an inotrope. So let's say now you've loaded the patient with fluids, different patient. The central venous saturation has moved from high 40s to low 50s. So you're showing some signs of improvement, but you're not quite there. And so that's somebody that might have been both volume responsive to a certain degree, but now you're dealing with a Starling curve that's pretty flat, not really that robust one that just pops up very nicely with fluids. You still have a little ways to go. It's based on kind of an imbalance between oxygen supply and demand as reflected by the central venous set. And so that would be a case where you'd start an inotrope. Or then, yet another example, you do a leg raise, there's not much change in the blood pressure, and then, to corroborate all that, you throw an echo probe on, poor function. That would be an inotrope again. So, types of inotropes that you can use. I divide them into two categories. Inoconstrictors consisting of epinephrine, dopamine, and inodilators. Inotropes that both improve contractility of the heart but also have effect on the peripheral vascular smooth muscle and dilate the vasculature, and that's dobutamine and milrinone. So if the blood pressure is low, and that part of your resuscitation is normalizing the blood pressure, then an inodilator is just going to make things worse because, yes, you'll improve your cardiac output, but probably your blood pressure will head down even further. And then you have to add on a constrictor, and then that might impair function, and then you're kind of in this vicious circle. So if your blood pressure is low, definitely reach for an inoconstrictor. And if later on down the road, if you feel like you need a vasopressor, and you already feel like your inotropic needs are not quite met by the native function, well, then in that case you want to use norepinephrine, say, instead of phenylephrine, because that has some beta effects that will then support the heart as you increase the afterload. If your blood pressure is adequate or just barely adequate, right on the borderline, you can try an inodilator. And in that context, what it tends to do is it improves contractility as well as dropping vascular tone. So if you kind of think about mean pressure as being a blend between vascular resistance and cardiac output, I like look at it this way, and that is you're picking up the cardiac output and you're dropping the vascular resistance, and you're doing that in a proportional manner, and most of the time you kind of have a break-even blood pressure. And so you might start with a map of 65 that is really made up mostly of high vascular tone and low cardiac output. And then with an inodilator, you've kind of rearranged those pieces. So now you actually have a more healthy blend between cardiac output and vascular resistance. And then that will allow that cardiac output to turn into meaningful oxygen delivery and be perhaps what you need in resuscitating that patient. So kind of analogous to what we talked about for the inotropes, what's the clinical context for vasoconstrictors? So again, you have a hypotensive patient. A neurointensive patient shouldn't be given a vasoconstrictor too. But a hypotensive patient, again, if you go down the ER, you see the patient, you look at the heart, the end systolic volume is adequate. Function looks robust. So often you're doing this echo to ask yourself, does this patient need a constrictor, an inotrope, more fluid? Here you've kind of answered all three questions here. Like, you're probably euvolemic, you don't need an inotrope, you definitely need something to improve the blood pressure, and that will be your vasoconstrictor. So you've loaded now another patient. Let's say you've loaded the patient with fluid, and then your function is hyperdynamic on echo. So again, you've done pretty much everything you can to help oxygen delivery, assuming that your crit is okay. You've given the patient fluids. You've asked yourself, do I need an inotrope? The answer is no. And then what's left? It's picking up the blood pressure with a constrictor working on the periphery. Let's say you do a leg raise on the same patient. You put an art line in, you put a leg raise in. You're looking at a map of 50 to start with. You pick up the legs, and you see that the blood pressure goes up to 60. Well, that tells you a couple of things. One is that the patient is fluid responsive, but also that probably if you give the patient fluid, you're probably still not going to make it to a map of 65 if, for example, that is your therapeutic target. So again, you've kind of answered a couple questions here. Function looks adequate because it's handling fluid fluid will get you some part of the where you want to be therapeutically, but not everywhere, not entirely there. So that's when you want to add a constrictor as well. Or let's just say you're initially assessing the patient, and the patient appears to be vasodilated. They're warm, they've got reasonable cap refill, pulses are bounding, but they look beet red. Everything tells you the patient's dilated. Well, totally fine, just start a constrictor. And again, you'd have to look at other aspects of oxygen delivery. You're not just going to put on a norepinephrine and normalize the blood pressure and say case closed, but that'll at least get you going on therapy that will bring the patient's pressure up and help perfuse the brainstem, the heart, and the brain. And let's just say that, similar situation, you start, say, an iron infusion on somebody and they tank their pressure and they seem very vasodilated. That's clinical context probably calls for perhaps a little bit of fluid, but certainly something to normalize the vasodilation that took place there. So you notice a couple of these items here are italicized, and these are pretty much the same items that were used in the discussion of when would you start an inotrope. But in this case, they are used for the constrictor. And so, remember in the inotropic discussion, when you look at the heart and the volume was adequate and the function was inadequate, well, then that's where you go for that sort of a decision point where you say, okay, let's not worry about blood, vasopressors right now. Let's at least get this inotropic state to where we think it needs to be, and you start an inotrope. Here it looked robust, so you went for a constrictor. You've loaded the patient with fluids. If the function is not good, and you still have signs of inadequate oxygen delivery or hypotension, then again, that would be somewhere where you start maybe an inoconstrictor. But here's hyperdynamic, so you start just a vasoconstrictor. And as you recall, when we did the leg raise in the patient that needed the inotrope, with the leg raise, the blood pressure didn't change. And so that would be someone who's not going to get any further bang out of fluids as far as blood pressure and oxygen delivery, but needs a little bit of help with supporting the heart. Here the blood pressure changed, so that's someone that can use fluid, but it didn't change enough, and so they also buy an inotrope. So let's take a look at a couple different clinical conditions that might evolve over the course of, say, taking care of a postoperative patient with a PA catheter. We'll take a look at some of the PA catheter parameters and how trends in some of the relationships between their findings might point you toward an inotrope or a vasoconstrictor. So we'll consider one example where, let's just say that this is kind of your target blood pressure here. That's looking pretty good. We'll diagram that in red, since that is what's going to be on your red line. Your heart line, CVP will give you a blue, P diastolic will give you yellow, and cardiac output we'll say is kind of smoldering along at a decent level. Okay, so consider the situation where you see the MAP drop and you see the CVP going up, some of your filling pressures going up. Sorry, that's a little bit faint. Make that thicker. And then during that same time, your cardiac output is going down. So what does that pattern look like? Unfortunately, this is a little bit of a can of worms because there could be a number of things going on, especially in a ventilated patient. This could be someone who's waking up a little bit, and there could be just some ventilator dysynchrony where the patient's kind of tensing up, and because of that, there's external pressure put on the various catheters that are within the body, hence creating an increase in some of the PA numbers, increasing some of the central filling pressure numbers, impairing venous return, knocking the cardiac output down, and then the blood pressure going down as well. So, but if you rule that out, you look at the ventilator and assure yourself that there's no changes in airway pressures, and let's just say that in fact the patient is heavily sedated and paralyzed and nothing else is going on as far as heart-lung interactions, then this could also be something like a pneumothorax and tamponade. But again, let's just say that you do the appropriate studies to rule that out. You put a TE echo probe in, and you do not, and fails to reveal any kind of compression of the heart or any new fluid collections. Well, assuming that all the bad stuff has been ruled out, this is a case here where perhaps heart function is heading down and it needs an inotrope to support it. And that's kind of corroborated by the fact that there's definitely fluids that are piling up behind the left heart, between the right heart, and what you measure for the cardiac output is low. And assuming that you're treating a problem, that the cardiac output and the blood pressure that you have are problematic, then this would be a situation where an inotrope, specifically an constrictor, given the low blood pressure, would be an appropriate choice. Okay, we'll go back to the drawing board. So let's say we've got the map, the CVP, PA pressures, cruising along at good steady state values. But in this case, we have a CVP that's maybe drifting down slightly, PA diastolic in wedge, drifting down very slightly, cardiac output starting to head up, and a blood pressure that's starting to really kind of head downhill. So, what does this sound like to you? What do you think that patient needs? And this is an example of a patient that you'd want to steer back to normalcy with a vasoconstrictor. Depending on what the heart rate is doing, you might, and if this cardiac output is really robust and the heart looks good, it's good, then something like phenylephrine might be totally appropriate, because you don't want to have a higher heart rate. Then let's just say patients like 105, 110, phenylephrine would be appropriate, norepinephrine would be appropriate. Vasopressin theoretically would too, although it does have kind of a limited range where you can titrate it. Okay, we'll round this out just with yet another example. So similar blood pressures, kind of doing okay, eventually drifting down. Cardiac output, pretty steady, now heading down. Pulmonary artery pressure, wedge pressure, P diastolic, pretty steady, then heading down. And finally, CVP, also kind of drifting down, completing that picture. And so what do you think the patient needs in this situation here? Hopefully the answer you came up with is fluids. So again, in the course of resuscitation, you give patients fluids and then you dial in the right levels of inotropes and vasoconstrictors, but these are dynamic pictures, and sometimes there might be some ongoing fluid needs that evolve through the course of therapy. And in this case, this is a pretty slam dunk picture of somebody who is becoming hypovolemic. So you want to make sure that the patient is not bleeding. So definitely make that part of your mental inquiry. And if not, if there's not some kind of source control or red fluid replacement or that's needed, then you're back to things like plasma, crystalloid, colloids, whatever you think is appropriate for that clinical situation. But this is hypovolemia. So inotropes and fluids and vasoconstrictors are all part of resuscitative strategies. And when you read about these, and especially in the experimental realm, people present nice flow diagrams of what they've done. And so it's good to understand a little bit about the logic behind these. And we'll talk a little bit about that right now. So this is a very successful strategy that was employed around 2001 by Rivers and colleagues for patients who had severe sepsis and septic shock. And what they did should seem pretty familiar to this discussion, is they first put in a CVP catheter. They got the CVP up to prove that the patient's fluid replete, then took care of low blood pressures with vasoactive agents, and then considered whether oxygen delivery was adequate or not, and transfused from red cells if the crit was less than 30, but used central oxygen saturation as sort of a marker for cardiac output in the setting of somebody whose V.O2 is probably similar through all these different measurements, and whose crit has been repleted. And so if there's inadequate tissue oxygenation as registered by central venous oximetry, then that would be someone who would need an inotrope. And so they would then add an inotrope in, and such would be their strategy. So I don't know if people follow these algorithms like do this, do this, do this, do that. I'm presenting this other alternative here, the so-called dashboard technique, is just as a way of thinking about what you're doing throughout time. And that is, you don't really, if the heart function is inadequate, you don't necessarily want to wait several hours till you've done all A through D before you get to someone who needs an inotrope and to give them an inotrope. And I've seen a lot of people wait a long time to see if somebody is fluid responsive, when at the outset they're clearly vasodilated and hypotensive. So why wait hours to see if they're fluid responsive and to see if they still have hypotension after you've given them a bunch of fluid before you start a vasoconstrictor? So I think what I would suggest is that you kind of consider 3 simultaneous issues in every patient that's in shock. And here we're talking about septic shock, but really I think all forms apply. And one is just, fluid management, making sure the vascular status is okay. And if they're hypervolemic, get rid of fluid. If they're hypovolemic, give them fluid. And assess that with whatever kind of monitoring that you have. Whether it's CVP monitoring, whether it's invasive PA catheter, or just bedside echo. Then there's the blood pressure management piece, where if someone's blood pressure is inadequate and you believe that there's a reason that they might be vasodilated, then go ahead and give them some vasoconstrictors. And in the course of evaluating contractility in fluids, and if you find some deficits in those areas, you'll add the appropriate agents, and chances are your vasoconstrictor concentrations that you're infusing will come down. And then simultaneously, you're also thinking about tissue oxygenation, or the supply-demand relationship. And so as you proceed with all these interventions, you're going to look at what your original markers for malperfusion are, whether it's physical exam, cold extremities, whether it's a lactate that's elevated, a metabolic acidosis. And then you'll implement various strategies to support contractility, to if they need inotropes, if function looks poorly, thinking about hematocrit and bringing the hematocrit up, but if it's inadequate, and even minimizing oxygen consumption with the use of sedatives, analgesics, and even mechanical ventilation if they're using extremes amount of oxygen to try to maintain a normal pH. And so I kind of think about this as things you're doing all at once. You're putting in IV lines, you're getting an echo to look at fluids, you've seen the blood pressure's pretty miserable, and so you're starting, say, a peripheral line that you can use vasopressors on and give some vasopressors while you're evaluating contractility and deciding about whether you want to give an inotrope. And so all this is kind of going on simultaneously, but nonetheless with a very orderly thought process, in the sense that as you're doing any of these interventions, you're asking yourself, am I delivering this patient an adequate blood pressure? And also, are the abnormalities in the V.O2-DO2 relationship improving as I do this host of interventions? So you can give somebody a normal blood pressure with a constrictor, and chances are you might be completely normalizing their blood pressure, which is great, but you might be completely poisoning the body and creating a huger mismatch between oxygen supply and demand. This is what happens in hemorrhagic shock, by the way. You lose a bunch of blood volume, you vasoconstrict, you've got a normal blood pressure, probably a sky-high heart rate, and then when you start looking underneath the hood and start looking at metabolic processes and lactate, you realize that, my gosh, this is an anoxic disaster before my hands. And so you don't want to create that yourself by just giving constrictors. You want to do something about the blood pressure, but at the same time, you want to ask about all these other relationships and optimize them. So here's a graphic description of the argument I was just trying to make. So let's say that you're starting out with a map that's not so great, but your target is 65, and so you're kind of smoldering along at whatever that blood pressure is there, and so you start to try to support that. So and this is time here. Sorry about that. Time. And so you support that by giving, say, a fluid bolus, because you're looking at the patient's fluid status and it looks like it's inadequate. And let's just say that through the course of first couple hours you give a few different fluid boluses because you think the blood pressure is responding to that, and indeed it just kind of does, and sort of nudges itself up sort of gently following the fluid bolus. And then after 3 liters you're wondering, hey, why is my blood pressure not responding really well? Sorry, let's just make the map of 65 up here. This is not working the way I'm drawing it. And so you start looking at, do I need to give an inotrope? And yeah, the heart looks a little bit sluggish. And so let's just say that you start a little bit of epinephrine here. And so that's helping the heart a little bit, bringing the heart up to nice, better blood pressure, but still not there. And then finally you realize, okay, well, wait a minute, after 3 hours, my blood pressure still isn't exactly what I need. Maybe I'll start some norepinephrine on top of my epinephrine. And then ding, 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 after 4 hours, I've received 3 liters of fluid, various evaluations, some epinephrine, norepinephrine, and now I finally reached my target blood pressure. So I want to contrast that with a slightly different style here, the kind of dashboard method, where you're kind of like looking at all the issues simultaneously, and the first thing you notice is the blood pressure really is not that good. And so, yes, you start to give some fluid boluses to this patient, but at the same time, you get another decent IV line in, and you start the norepinephrine, which I guess was purple down here. But then as you look at the heart, you realize, okay, it's a little bit empty. So you need to give some more fluid. So indeed you do that. And your blood pressure is staying the same throughout all this, but what's happening is the amount of norepinephrine that you're using, is starting to head down. And so then it looks like you might need a little bit more fluid, so you give, say, another half a liter, but patient doesn't look completely dry. So again, as time goes, your norepinephrine levels start to head down, and then you start looking at the contractility and realize, it's not all that great. My mixed venous or central venous O2 sats aren't quite up to where I think they should be, and so you reach for some epinephrine or maybe even some dobutamine because your blood pressure is okay, and you start a kind of a low dose inotrope infusion, and you continue your norepinephrine infusion, and then at the 4 hour point, you've got the same blood pressure as you did as when you took the more kind of algorithmic do this then that and follow very strict order. So you're on an inotrope, you've gotten some fluids, you're on a vasoconstrictor, but what's the difference? You've had a normal blood pressure for hours as opposed to just more recently in this situation here. And so I think I personally feel like this seems like a better thing for brains and for myocardial perfusion, other organ perfusion. The main issue, though, is that you can't just say, my blood pressure is okay, I'm not going to evaluate the heart and consider whether the patient needs inotropes or additional fluids. This is where things could be an absolute disaster. But if you're honest with yourself and that every time you're doing something or employing a new intervention, you're looking at the V.O2 relationship as well as the blood pressure, then that will lead you to the right answer. And I think that this longer period of stability, although I can't prove it, I think that in the end we'll find makes a big clinical difference. So just kind of a summary of tools that we've talked about in evaluating whether patients need inotropes or vasoconstrictors. I think the whole world is turning toward echo. I'm a huge proponent of that myself. It's great at making initial decisions about inotropes versus vasoconstrictors, but a couple caveats need to be kept in mind. One is sometimes if you're just looking at the heart, you might miss some valvular pathology that's important. But also is through time, you can develop myocardial depression. So that one snapshot that you've taken of the heart that you've used to make a clinical decision is nothing more or less than that. It's just one snapshot of that one period of time. And it probably is valid for a few hours, but if things aren't making sense, you have to go back and say, maybe the heart function has changed and take a look for that. The other thing too is I've talked about using it as kind of deciding what the next drug is, inotropes or constrictors. Often you need a little bit of both. And so you need inoconstrictors, you need inodilators, and sometimes you put on one drug and you realize, okay, I need another one. It's not a big deal. It doesn't mean that you made a bad choice. That's just life, and that sometimes these are multiple choices that you're making at the same time. They're not exclusive. So central venous O2 sats, they're great for following changes in cardiac output. They're actually available through CVP catheters if the patient has them. If patient's on the floor and they have a PICC line, you can obtain a sample from the end of a PICC line. Same thing for a dialysis catheter. If you get rid of the heparin in the middle of it and you're desperate for some kind of value, you can always use that. The caveats of that measurement are that it looks at the supply-demand relationship, and there's three variables. There's V.O2, and there's the two components of oxygen delivery. There's hemoglobin and cardiac output. And so if you're using it as a way of surmising what's going on with cardiac output, you have to make sure that the other two factors are relatively constant over a series of measurement. So if you have someone that's like sedated or paralyzed and just kind of hanging out in the bed without any changes in temperature or gross large motor activity, then probably V.O2 is very much the same through a whole course of measurements. And if the crit's about the same, then I think you can pretty much deduce that changes in your central venous saturation are due to changes in cardiac output. The other thing is in kind of high inflammatory load situations where there's a lot of mediators of inflammation and reactive oxygen species that impair mitochondrial function, sometimes your tissues are just acting like shunts. They're not taking up oxygen, even though they very much could use some, but you just get basically a lot of unused oxygen from hemoglobin, and your saturations often don't reflect the severity of disease or changes in tissue function as related to things that you're doing as far as changing cardiac output and changing vascular tone. So when the mixed venous or central venous sats are low and you see some changes fluctuating around these less than 70 measurements, say, then chances are they're pretty real, but oftentimes in critically ill patients, you'll just get measurements that are in the 70s that don't really change that much with what you're doing. So PA-cath monitoring, it is great for trending. It's great for understanding what's going on in the pulmonary circulation. It's great for understanding relationships between fluid loads and cardiac output and inotrope use and cardiac output. But sometimes in the course of using it, you create these little mini therapeutic endpoints which might not be real unto themselves. And so you might be convinced that getting somebody's index back to 3 is like the goal, even though they might have normal oxygen supply-demand relationships at indices of 2.5. So be very careful about what kind of numbers you're shooting for, especially when you have a catheter that is generating lots of numbers. Really, the therapeutic goals here are blood pressure that's within a patient's autoregulatory range and an oxygen delivery that is at least twice of what's being demanded. And so, targeting CVPs and P diastolics and mixed venous stats and indices and so forth, those are great numbers that you can put together for trends and for stories about how somebody got to where they are and what's going to make them better, and also provide some tools for helping them get better. But those are not therapeutic endpoints, and that can be counterproductive sometimes. Okay, well, I think that's enough on this subject. Thanks very much for your attention. Hope this was informative.